Welcome to the Radiographics Podcast. I'm Wende Gibbs. This week, my co-host Frederick and I will be discussing two more cutting-edge articles from the current issue of Radiographics and an upcoming issue. You heard it here first. I'll share a multisystem paper on a topic that we must be increasingly aware of: side effects of cancer treatments that we may see on PET or CT. As cancer treatments are improving and more new treatments are being used, we're seeing new adverse effects that we must know, so we know what to say in our reports, and so we don't confuse them with progressive malignancy. And Dr. Frederick is going to summarize an upcoming paper on an amazing, relatively new interventional technique, Geniculate artery embolization, which promises to alleviate pain in those with knee osteoarthritis. That'll be intriguing for many of our listeners. Let's start with the multisystem paper. Side effects of oncologic treatment in the chest, manifestations at FDG PET-CT. PET has a well-established role in guiding cancer therapy, including staging, monitoring treatment response, and restaging following completion of therapy. Patients who are undergoing or have completed oncologic treatment can have a broad range of treatment-related complications, and these are often seen on PET. Treatment-related adverse effects often involve inflammatory changes, resulting in increased FDG uptake. And it's important to distinguish these findings from malignancy, or if the findings are nonspecific, provide an appropriate differential diagnosis within the context of the patient's therapeutic history. As a review, we remember that the biochemical mechanism of FDG PET involves cellular uptake of FDG, a glucose analog, by glucose transporter membrane proteins. Following intracellular transport, FDG is phosphorylated by hexokinase, which traps FDG within cells, resulting in an image that reflects the sites of increased cellular glucose metabolism. Given this mechanism, the activity seen on PET is not specific to malignant cells. Normal physiologic pattern uptake shows intense activity in organs with increased glucose metabolism, such as the cerebral cortex and activated brown adipose tissue. And benign pathologic uptake is commonly due to inflammation, with increased uptake by activated leukocytes. Treatment-related inflammatory processes often demonstrate FDG avidity and may mimic progressive malignancy. An example is sarcoid-like granulomatosis, which is SLG, an immune-related adverse event associated with checkpoint inhibitor immunotherapy. In addition, uptake by leukocytes can be due to infectious causes, which are commonly seen in immunosuppressed patients after intensive chemotherapy or stem cell transplant. These infectious causes include opportunistic infections such as disseminated fungal infection, which may be mistaken for tumor. Overall consideration of prior serial imaging findings, including knowledge of the original sites of malignancy and an understanding of characteristic PET findings, helps to distinguish adverse treatment effects from progressive malignancy. Other adverse effects are less likely to be mistaken for malignancy on the basis of correlative CT findings, although recognizing key imaging features that are suggestive of specific complications can expedite the clinical diagnosis to guide therapeutic management or prompt further evaluation. For example, the identification of typical findings of organizing pneumonia make us wonder about possible drug-induced pneumonitis, and an accurate diagnosis can help guide clinical decision-making, so potentially modifying oncologic therapy and initiating treatment of pneumonitis. Recognizing the sequela of recurrent aspiration in a patient with a history of prior radiation therapy adjacent to the esophagus should make us think of and look for airway esophageal fistula. And even if a fistula is not seen, it should prompt appropriate further evaluation. Let's start with pulmonary parenchymal complications. Drug-induced pneumonitis is a relatively common adverse effect seen in about 20 of 100 patients treated with antineoplastic agents. However, the incidence is dependent on the specific agent, dose, and concurrent therapies. Although with some agents, such as bleomycin, drug-induced pneumonitis is associated with a certain cumulative dose, in many cases it's idiosyncratic. The pathogenesis of drug-induced pneumonitis includes direct cytotoxicity to pneumocytes and alveolar capillary endothelium, immune-mediated effects resulting from cytokine release or leukocyte activation or dysregulation, and oxidative injury. Lung injury manifests in a limited number of histopathologic patterns with corresponding characteristic CT findings. Lung injury patterns include organizing pneumonia, nonspecific interstitial pneumonia NSIP, eosinophilic pneumonia, diffuse alveolar damage or acute lung injury, diffuse pulmonary hemorrhage, hypersensitivity to pneumonitis-like pattern, and usual interstitial pneumonia. Now, wow, that's just about all the patterns I think I had to learn for boards. Pathologically, organizing pneumonia demonstrates plugs of granulation tissue within the distal airways and alveoli. Clinically, organizing pneumonia has constitutional symptoms and shortness of breath, although it may be asymptomatic. Characteristic CT features include peripheral or peribronchovascular consolidation and or ground glass opacities. The reverse halo sign or atoll sign of central ground glass opacity with peripheral consolidation is specific, although it's only seen in about 20% of cases. Band-like and perilobular or polygonal consolidation also is highly suggestive. On PET-CT images, organizing pneumonia demonstrates increased FDG uptake, with the greatest uptake in areas of consolidation and the degree of uptake corresponding directly to disease activity. How about radiation-induced pneumonitis? The effects of radiation are unique in that they're confined to the area of the radiation port, often with abrupt linear borders of involvement that distinguish post-radiation effects from other pathologic entities. Makes it a little easier. On histopathologic analysis, radiation-induced pneumonitis demonstrates a characteristic time course following completion of radiotherapy, with corresponding PET-CT findings. Radiation-induced acute pneumonitis begins as an exudative phase characterized by a pattern of diffuse alveolar damage lung injury within the irradiated field. There's a lag in the clinical and imaging manifestations, which typically appear about 4 weeks following radiotherapy completion. If the acute post-radiation pneumonitis is mild, it may resolve with restoration of normal lung parenchyma. However, if the post-radiation pneumonitis is severe, the acute exudative phase will progress to a proliferative phase at 3 to 9 months following radiation completion, with evolution to late pneumonitis or fibrosis at 9 months to 2 years. Signs of recurrent disease include focal FDG activity within the irradiated field in the late phase, a new convex contour or lobulation seen on CT, and new focal airway obstruction in the area of late pneumonitis changes. Radiation recall pneumonitis may be seen in the irradiated field following the initiation of chemotherapy, targeted therapy, or immunotherapy agents. This is a delayed adverse effect that may occur 6 months to years following the completion of radiotherapy. Immunosuppression, such as neutropenia from intensive chemotherapy or stem cell transplant, predisposes oncologic patients to pneumonia from typical bacterial organisms, fungi, viruses, and mycobacteria. Overall, bacterial organisms are the most common cause of neutropenic pneumonia. However, invasive fungal pneumonia is of particular concern, given the significant morbidity and mortality associated with this infection. Aspergillus is the most common pathogen in the invasive fungal pneumonias in neutropenic patients. Typical CT features of angioinvasive fungal pneumonias include parenchymal nodules and consolidation, often with surrounding ground glass, resulting from associated hemorrhage, providing the characteristic halo sign. Associated cavitation and pulmonary infarcts are also seen. Invasive fungal pneumonia is an important differential consideration for new hypermetabolic pulmonary nodules or masses that are concerning for metastases or malignant recurrence, especially in patients with immunosuppression, which in many cases cannot be distinguished on the basis of clinical and radiologic findings and may require biopsy for a histopathologic diagnosis. How about airway and pleural complications and post-treatment effects? Bronchopleural fistula most commonly occurs as a post-operative complication following lung resection, although it's also an uncommon complication of necrotic lung masses, particularly after radiotherapy and/or chemotherapy. On CT images, a direct communication between the airways or lung parenchyma and the pleural space may be evident, although a persistent hydropneumothorax or pneumothorax is an indirect sign that's highly suggestive. Acquired tracheoesophageal or bronchoesophageal fistulas most commonly occur in patients with mediastinal malignancies, particularly esophageal cancer, before or after treatment with radiotherapy and chemotherapy. Although a direct communication may be visualized with CT, the fistula tract may be collapsed at the time of imaging. Given this, if there's clinical concern, fluoroscopic or CT esophagography should be performed to confirm the presence or absence of the fistula. Indirect CT findings of airway esophageal fistula include recurrent aspiration with dependent acute on chronic inflammatory changes, and this may be the initial sign that triggers further evaluation. Okay, here's one I remember seeing a lot as a resident, talc pleurodesis. Talc pleurodesis is a treatment for persistent pleural effusion or pneumothorax that may be encountered in oncologic patients and is notable for associated persistent inflammatory pleural FTG avidity. While inflammatory pleural FTG avidity is not a complication, it's important to be aware of this expected post-treatment finding that may mimic malignancy. Pleural talc administration results in an inflammatory response that promotes pleurodesis, with histopathologic analysis demonstrating formation of pleural granulomas that evolves to pleural fibrosis. On PET images, there's an increased pleural uptake, which may be linear or focal and may persist for more than 10 years following the procedure. On CT images, there are corresponding areas of pleural thickening or nodularity with high attenuation foci on non-contrast images corresponding to the pleural talc. In terms of systemic complications, there are a variety of immune-related adverse events associated with checkpoint inhibitors, and these can manifest in any organ. Sarcoid-like granulomatosis is an adverse event with thoracic manifestations that can mimic recurrent malignancy. It manifests with characteristic imaging and histologic findings of sarcoidosis that typically involve the lungs, as well as mediastinal and hilar lymph nodes, although it may involve other lymph node regions and the spleen. In addition to being an immune-related adverse event associated with various immune checkpoint inhibitors, sarcoid-like granulomatosis has long been reported to have a broader relationship with cancer itself, with an unclear pathologic mechanism. That's interesting. Characteristic FDG features of FLG include FDG-avid pulmonary micronodules, or focal round consolidation with surrounding ground glass, symmetric FDG-avid lymphadenopathy, typically with mediastinal and hilar involvement, and hypermetabolic splenic lesions. Care should be taken not to mistake SLG for hyperprogression or pseudoprogression after immunotherapy. Mediastinal complications include thymic hyperplasia and esophagitis. Thymic hyperplasia typically occurs 3 to 14 months after the initiation of chemotherapy, but it may be delayed for up to 5 years. On PET images, the thymus is enlarged and often has diffuse, marked FTG uptake. Features that distinguish thymic hyperplasia from malignant involvement include diffuse enlargement, smooth contour, maintained typical inverted Y configuration, and normal intervening fat, lymphoid tissue, and vasculature. Treatment-related esophagitis can develop secondary to chemotherapy, immunotherapy, or radiation therapy. Risk factors for radiation-induced esophagitis include radiation dose and concurrent chemotherapy administration. PET demonstrates increased linear FTG uptake along the esophagus, with correlate CT findings of esophageal wall thickening. Radiation-induced esophagitis demonstrates sharply demarcated cranial and caudal margins of involvement corresponding to the radiation field. In the lungs, you can have pulmonary embolism or tumor thrombus. The FDG avidity of tumor thrombus correlates with that of the underlying malignancy, and focal uptake is suggestive of tumor thrombus, whereas linear intramural uptake is seen equally with bland thrombus or tumor thrombus. Contrast-enhanced CT findings are also helpful in differentiating tumor thrombus from bland thrombus, with the CT features suggestive of tumor thrombus including direct extension from extravascular tumor, intrathrombus enhancement, and marked venous expansion. In the skeletal system, you can have osteitis and osteoradionecrosis. Radiation osteitis develops within the irradiated field after a latent period owing to damage to the osteoblasts and resultant bone matrix resorption. Radiotherapy initially results in osteopenia after approximately 1 year. Subsequently, after 2 to 3 years, coarse trabeculae develop with areas of mottled osteopenia and sclerosis. The late findings of radiation osteitis have been described as having features similar to Paget's disease, but without bone expansion. Rarely, radiation osteitis progresses to radionecrosis, particularly within high XRT doses, and patients may have pain and increased metabolic activity on PET years later, mimicking recurrent or metastatic malignancy. Radiation osteitis and osteoradionecrosis also predispose individuals to pathologic fractures. CT findings of osteoradionecrosis, including lack of a soft tissue mass and characteristic sclerosis, can help distinguish this condition from recurrent malignancy. Risk factors for radiation-induced osteoradionecrosis include high radiation dose, high radiation beam energy, and osteoporosis. This is a great article with fantastic pictures of all these things and more, so check it out online or in the print journal. Now let's switch gears and learn about this intriguing, relatively new procedure to treat the widespread scourge of so many individuals, osteoarthritis in your knees.
Geniculate artery embolization, role in knee hemarthrosis and osteoarthritis. Osteoarthritis of the knee is an extremely common source of morbidity around the world, and about 40% of Americans over age 60 experience chronic knee pain from osteoarthritis. Although surgery has proven to be an effective treatment of knee osteoarthritis after conservative measures fail, operative intervention may not be ideal in patients who wish to avoid invasive procedures, or for those who are poor surgical candidates because of underlying medical comorbidities. So then what's the solution? Geniculate artery embolization. This is an up-and-coming procedure which was first described in 2015. It is a minimally invasive intra-arterial intervention that selectively embolizes the geniculate branches corresponding to the site of pain or hemorrhage. These arteries supply nutrients to the synovium and play a pivotal role in perpetuating the cycle of inflammation, synovial hypertrophy, and angiogenesis seen in osteoarthritis and recurrent hemarthrosis. Geniculate artery embolization stops the cycle by directly closing the geniculate arteries supplying the region of interest and inhibiting the inflow of pro-inflammatory mediators that contribute to synovitis and joint vascularity. In this article, the authors review the clinical and radiographic findings of recurrent hemarthrosis and osteoarthritis of the knee, as well as the role of geniculate artery embolization in the treatment of these pathologic conditions. First, let's discuss hemarthrosis, which is hemorrhage within the knee joint. It is most commonly seen in the setting of trauma. However, other notable causes include inherited or acquired bleeding disorders, such as hemophilia and post-instrumentation hemarthrosis. These non-traumatic causes can predispose patients to recurrent hemarthrosis, thereby resulting in advanced osteoarthritis and knee replacement. Endovascular closure of the geniculate arteries in the region of hemorrhage may prevent accumulation of hemorrhage within the joint and reduce pro-inflammatory mediators and stop the cycle of synovial hypertrophy, angiogenesis, and cartilage destruction. People with knee hemarthrosis often present with a painful, warm, stiff, and swollen knee. The chronicity of intra-articular hemorrhage results in advanced degenerative changes and risk of septic arthritis. Early diagnosis and treatment can help reduce the risk for joint destruction. When hemarthrosis is suspected, plain film radiography is the initial preferred imaging modality. Lateral view shows a joint effusion with fluid levels as well as displacement of the patella or quadriceps tendon. In children or patients with underlying coagulopathies, dedicated ultrasound can be used to visualize the complexity of the joint effusion. If hemarthrosis is in the setting of trauma, cross-sectional imaging may be required to evaluate for an underlying fracture using CT or ligamentous injury using MRI. In addition to seeing fluid levels in the suprapatellar joint space, MRI may help identify synovial hypertrophy and enhancement while also shedding light on the underlying cause, which could be a ligamentous, soft tissue, or osseous injury. In chronic hemarthrosis, MRI shows long-term sequelae of intra-articular hemorrhage, including cartilage and meniscal destruction. Joint aspiration is the reference standard technique to confirm hemarthrosis. Aside from confirming the diagnosis, joint aspiration can often be therapeutic for patients by reducing the intra-articular pressure. Initial treatment of hemarthrosis is conservative, which may include joint aspiration, immobilization, compression, ice, and analgesics. However, this only resolves the hemarthrosis in 1/3 of cases. For patients with hemarthrosis that does not improve with conservative treatment, open or arthroscopic synovectomy are effective treatments. However, this invasive approach is associated with significant complications, including loss of articular function and infection. Studies have suggested pursuing geniculate artery embolization before surgical synovectomy in these instances, given its efficacy and perceived lower morbidity. Now let's move on to osteoarthritis. The overall pathogenesis of osteoarthritis results from a combination of biomechanical wear and tear factors and chronic pro-inflammatory mediators. Understanding the inflammatory and biomechanical mechanisms of osteoarthritis is critical to understanding the therapeutic target of geniculate artery embolization. Knee osteoarthritis develops from excessive joint burden that leads to biomechanical degradation of articular cartilage. As a result of the mechanical damage, the inflamed synovium stimulates pro-inflammatory cytokines that encourage angiogenesis. Angiogenesis fuels the inflammatory drive and potentiates degenerative osteoarthritic changes. The new outgrowth of vascular networks serves as a highway for the transport of inflammatory and catabolic mediators to the synovium and neighboring joint tissue. As inflammatory mediators reach the target tissues, they induce further inflammation and hyperplasia. The result of this cycle is local cartilage destruction as well as sensory neoinnervation that contributes to pain. Therefore, the embolization of the vessels potentiating this cycle is the target of the geniculate artery embolization. The severity of knee osteoarthritis is best assessed on upright AP weight-bearing radiographs, where it is characterized by osteophytes, joint space narrowing, subchondral sclerosis, and bone deformity. As with hemarthrosis, initial treatment is conservative, starting with pharmacologic treatment such as NSAIDs. If symptoms are resistant to this, minimally invasive options are offered, including intra-articular corticosteroid or hyaluronic acid injections for short-term relief. Refractory symptoms often indicate a severe pathologic condition and likely require more invasive intervention, such as knee arthroplasty. Geniculate artery embolization may serve as a minimally invasive option to complement the current management protocol for mild to moderate knee osteoarthritis before knee arthroplasty. A fundamental understanding of knee anatomy is critical for identifying and embolizing target vascular supplies in a safe and efficacious manner. In knee osteoarthritis, the medial joint compartment has a 5 to 10 times higher burden of disease than the lateral compartment. Therefore, branches of the medial and descending geniculate arteries are often the embolization targets. Geniculate artery embolization usually targets 2 or 3 hypervascular vessels per knee, given the need to preserve some blood supply to the joint capsule. Now, as I was reading this article, I was wondering if performing geniculate artery embolization would significantly impair the ability to repair future insults to the knee due to vascular compromise. However, recent studies have reported total knee arthroplasties that have been successfully performed without complications in patients with prior geniculate artery embolization. Let's delve into the nitty-gritty of the procedure. Before catheterization, a general target for embolization is first identified externally with palpation. If pain is present, a radiopaque marker is applied to the skin overlying the site. Femoral access is ideal. An angiographic catheter is advanced to the distal superficial femoral artery. Angiography is performed to identify the appropriate genicular branches supplying the regions of hyperemia near the radiopaque marker, which appears as synovial blush. The abnormal genicular branches may be hypertrophied relative to unaffected branches. A superselective microcatheter is then advanced into the genicular arteries. After confirming the location of the microcatheter within the target vessel, embolic material is delivered until appropriate pruning of the neovascularity is visualized and pathologic hyperemia has resolved. An additional 1 or 2 vessels can be treated in the affected knee. This outpatient procedure can be completed within 1 to 2 hours. To avoid non-target embolization, it is important to be cognizant of cutaneous branches that may extend to the skin or collateral communication with other vessels. A relatively vigorous power injection before embolization can be used to better characterize this anatomy. In the setting of prominent cutaneous branches in the treatment zone, an ice pack can be placed around the knee to limit the amount of embolic agent that may migrate to the skin and cause discoloration. So what's the best way to embolize it? Particulate embolics are used for geniculate artery embolization in the setting of both hemarthrosis and osteoarthritis. Now, how successful is geniculate artery embolization in treating hemarthrosis? After initial treatment, 3/4 of patients experience clinical success which means they had no recurrent hemarthrosis within the follow-up period. If initially unsuccessful, many patients received additional embolization sessions, the majority of whom achieved clinical success. Similarly, geniculate artery embolization was also successful in achieving clinical success in the setting of osteoarthritis. Interestingly, geniculate artery embolization had superior outcomes for patients with mild to moderate osteoarthritis compared to those with severe osteoarthritis. As such, the ideal candidate should have mild to moderate osteoarthritis that is refractory to conservative treatment for over 6 months. Although geniculate artery embolization may provide lasting pain relief and functional improvement for some patients, initial results point toward a durability of response between 6 and 24 months. Therefore, geniculate artery embolization may best serve as an effective adjunct therapy that can reduce the use of other conservative therapies and delay or prevent surgical intervention. Any major complications of geniculate artery embolization? Not really. Complications are minor, transient, and mostly depend on choice of embolic material. The most common complication after geniculate artery embolization is transient cutaneous erythema, which is self-limiting. Now let's recap. Geniculate artery embolization is a safe, effective way to treat both hemarthrosis and osteoarthritis, and should be considered in patients who fail conservative measures and who also want to avoid surgical management. And remember, the ideal candidate for geniculate artery embolization should have mild to moderate osteoarthritis that is refractory to conservative treatment for over 6 months.
That is really amazing. What a breakthrough. Okay, we're out of time. We can't wait to see you all at RSNA. Come visit us at the radiographics booth. And we'll be back in 2 weeks for more summaries.